Med-Surg chapters are about 50 pages long, and half of the time you can tell what is important. Before we get into the details, I would like to zoom out first to look at the big picture of the chapter. I use a concept map like these to break it down heavy chapters. Coordinating care for patients with skin disorders. Introduction. This chapter 50, it's about skin, and we have these 7 skin disorders plus the recovery for surgery which involves skins. But here these 2 categories, they talk in immunity unit. For skin trauma, they talk about burns, but also it's in the next chapter. For cancer, skin cancer, they talked also in previous chapter, but also in cancer chapter that was related only for cancer. And we start with introduction. We repeat again that the role of skin has protection from microbial or chemical or ultraviolet injury. Also has sensation, that is another role, sensation, which means touch, pain, temperature, pressure. Also another role is for the water balance, which is retention and excretion. Absorption is for topicals. Thermoregulation, it's sweat, vasoresponses. Also another role is to immune surveillance. The fancy 6 secret cells, Langerhans cells, resistant flora, vitamin D, and metabolism. Clinical frame has disorders may be local, trauma to infection, or reflect systematic disease, which means immunosuppression, diabetics, vascular disease. Nursing priorities can be early risk of to ID, for instance, Barden scale. We talked on previous chapter on assessment about Barden scale with pressure injuries. So pressure injuries, it's the old, before used to say pressure ulcers. Now it's a new way to say, and we say pressure injuries because it's an injury. And meticulous assessment we need. Infection prevention, wound bed preparation, patient education, attention to body image or stigma. So disorders of skin may be related to local damage or trauma or indicative of systemic disease. Here is my concept map that all those categories goes on subcategories, and the chapter will be, and this video also will follow this structure. And we have bacterial skin infection with epidemiology, complication, pathophysiology, clinical manifestation, intrapersonal management with medical and nursing management, and they're all subcategories. And for each of them, they have the same, a little one like a flashcard. We call it the flashcard of a disease. So we have like 7, but this is like after the surgery. This also was mentioned in Post-operative, operative unit with chapter 15, 16, 17 from Davis Advantage, medical surgical. And yeah, so we'll go one by one. The next we'll start with bacterial skin infection. And here it's, as we know, the most is the Staphylococcus aureus and MRSA. Epidemiology, its common pathogen, the Staphylococcus aureus, Streptococcus. The group A, the risk factor is from skin break, shaving, eczema, dermatitis, obesity, edema, IV drug use. We have also surgery, trauma, peripheral vascular disease. For pathophysiology, we have uncomplicated and complicated. So uncomplicated is limited to dermis, like those impetigo, folliculitis, furcular, carbuncle, and complicated skin infection. It's a deeper or necrotizing. It's a cutaneous abscess with surrounding cellulitis, diabetic food infection, necrotizing fasciitis. And then we have clinical manifestation. How they look, we need to know all those terms, how they look, especially for quiz and for our patient. Teaching, impetigo is a honey-colored crust. Folliculitis is the pus-pool centered on hair follicle. And then we have carbuncle, which is painful nodule boils, and cellulitis is diffuse warm erythematous tender plaque, cutaneous abscess, necrotizing fasciitis. So it's a pain out of proportion. Medical management, we have diagnostic, the culture before antibiotics. We always do that. So first we do the culture, a little biopsy, and then we start antibiotics. So CBC, ultrasound for cold abscess, CT, MRI for deep infection. Also the biopsy for foot infection. We have the therapy for impetigo is topical. Also, we have oral antibiotics. For folliculitis, we have warm compress, but also oral antibiotics. Cellulitis, so it's like a mild, like a low dose of antibiotic, like doxycycline and cefalexin. For necrotizing, we have like an emergent surgical debridement with antibiotics. Tetanus prophylaxis as indicated. Then we have assessment here for nursing management. Is the assessment vital signs, pain vital signs is because the fever, we need to know the fever, and the blood pressure and heart rate. Pain, it's another virus to measure. We have to lesion mapping, like the drainage amount. We need to make sure if it's has edema or it's a risk for sepsis. Review comorbidities and meds to diagnose is acute pain, impaired skin integrity, risk for infection, spread, knowledge deficit, disturbed body image. Action, nursing action. It's a culture collection, wound cleansing with normal saline, packing after IND, moisture balance dressing, monitor for eschar, necrotics, administer and monitor antibiotic, analgesia, elevate affected limb, contact precaution for draining lesion. Nursing teaching, it's hand hygiene, wound care, complete antibiotics, avoid shaving personal items, avoid sharing personal items, return precaution like fever, worsening erythema, MRSA prevention. Outcomes, it's to be febrile, means no fever, shrinking erythema, decrease pain, so the skin gets intact. The wound bed will be with no new lesions. Herpes simplex virus. So this is a viral, and so we have to think that the complication, first of all, it's I always say GH because G is from genital, H from herpes. And the epidemiology says here it's the herpes simplex 1 and 2. The genital is a 2 lifelong lenticles in sensory ganglia. Reactivation with stress, fever, ultraviolet light trauma, and immunosuppression. Pathophysiology and clinical manifestation. It's group vesicle on the erythematous base. So it's an erosion, crust, prodrome of burning, tingling. Special forms, it's herpetic with low, and eczema herpeticum, atopic dermatitis, keratitis, disseminated disease in immunocompromised. Then we have, so the diagnostic confirmed with the PCR of a swab. Treatment, oral, this is viral medicine. Aciclovir is very common medicine. IV aciclovir if severe, topical for minor lesion. For the nursing is the pain control, prevent transmission, avoid contact during prom, vesicle, hand hygiene, no contact lens, waiting with saliva, psychosocial support. So the most devastating time to cure genital herpes is during pregnancy. So this is very sensitive, and because the complication of disseminated neonatal herpes carries a mortality rate up to 30%. So take care of our new mama and the baby. Because the viral load is much greater during a primary herpes simplex virus infection. The greatest risk of maternal transmission occurs among women who acquire a primary infection in the third trimester of pregnancy, as opposed to those recurrent disease. It takes about 12 weeks for the neonate to passively acquire maternal antibodies. And when the pregnant patient is infected in the final trimester of pregnancy, immunity may not be developed in time to protect the neonate during delivery. So the infant will have some problems. So those antiviral medications have been shown to be safe for use during pregnancy and should be prescribed for women who contact this genital herpes in the first or second trimesters. Cesarean sections are generally recommended for those type of patients which presenting with primary this type of lesions, because we just want to prevent delivery and in the last 6 weeks of pregnancy because of high viral shedding. So the longer you wait, the viral gets stronger and stronger. So the C-section, cesarean, we call it C-section. It's 6 weeks, so you have enough time to not to be that strong, the virus. And so will affect the neonate, but in the same time, it's better than 6 weeks later. But yeah, look more on the chapter for immunity for this. Fungal infection. Overview of fungal infection. We know it's one of this type of skin infection. So we know skin infection might be bacterial, viral, or fungal in origin, and each of has characteristic clinical manifestation. Treatment is based on identifying the specific pathogen and administration of target antibiotics and other therapies. Patients with skin infection might also manifest issues related to stigma and body image disturbance because of this skin infection, requiring sensitivity by the healthcare team. So we know that the fungal infection can be spread directly from person to person, although also throughout animal contact or indirectly throughout the contact with inanimate object that hold skin scales from infected host. This cell dermatophytes are aerobic fungi that infect the stratum corneum. So this is the top dead layer of the skin, and survive on keratin, and therefore cannot survive on mucosal surfaces. Typically a fungal infection with dermatophytes presents asymmetrically on patients affecting one foot or one hand. Candida also, it's very known in healthcare by nurses. So the risk here, we have few risks: communal showers, diabetics, also walking on the beach or in the showers. That's why they say communal showers. Tinea corporis, Tinea pedis, and Candida. So bright red plaques with satellite pustules. In the book, it shows exactly the pictures, and they're really pretty, and the table, so there it's nice to go and check. We have diagnosis, so fungal culture, wood lamp. Treatment, it's topically mostly, but also we have like some oral medicine. Nursing is keep area dry, footwear hygiene, avoid topical steroids on dermatophytes infection here, treat contacts in cavities. So some of those treatments you find over the counter. And I think that's it for here. Overview of psoriasis. So what we know about psoriasis, it's it's a skin issue, but it's not a fungal. So it's not fungal. It is an autoimmune disorder that causes the skin cell to grow and accumulate rapidly. Could lead to formation of thick, skulky patches on the skin. Psoriasis is not caused by a fungus, but it can be triggered by factors such as stress, infection, and certain medication. And so similar to patients with skin infection, patients with psoriasis may also have concerns related to body image because of chronic nature of this disorder. And so it's a lifelong inflammatory disorder, and it's characterized by exacerbation and readmission of raised, skulking, erythematous plaque, usually seen on the extensor surface of the body. Although there is no cure for psoriasis, there are various treatments available that can control clinical manifestation. And so it significantly affects the quality of life of an individual patient and the family. The effects of the disease are not necessarily proportionate with the extent of disease on an individual. So this can lead to psychosocial stress, poor self-esteem, financial worries, increased pain and discomfort, and infection. A baseline skin assessment is necessary to identify the location, quality, quality and quantity of plaques and areas of infection, and to evaluate the effectiveness of the treatment. We know by clinical manifestation of psoriasis include the thickening of the epidermis related to silver white scales over red circumscribed thickened plaques. Patients with psoriasis are at higher risk of developing non-melanoma skin cancer and can lead to impaired mobility and restrict activities of daily living. And more of the half of the patient, like 50% of the patient diagnosed with psoriasis complain of physical pain as well as physical irritation and itching. Because of those, because there is a high rate of psoriasis within family, it is important to obtain a detailed family history. What else? Yeah, for those patients presenting with clinical manifestation of psoriasis. The assessment also focus on conditions that increase the risk of psoriasis, including immunocompromise and or immunosuppression and impaired skin integrity. We have because of the skin changes associated with this disease, patients often manifest issues around personal appearance, leading to an increased risk of depression and anxiety. Obsessive behavior and difficulty expressing emotion, such as anger, depression, and low self-esteem are associated with psoriasis and can lead and can be so debilitating that patient contemplate suicide. Pathological anxiety can worry occur because of the effect of avoidance behavior. Stress and anxiety have deleterious effects on the response to treatment and can exacerbate the disease. Here we have we need to make sure that we teach the patient and understand their we need to support body image. Also, we have to make sure that whatever triggering, and then we need to evaluate the outcome. So it's better to address emotional and psychological stress because physical clinical manifestation have proven to be crucial in the management of psoriasis, providing emotional support, allowing the patient to verbalize concerns, and referral to the appropriate providers and support groups can improve overall quality of life. Educating the patient and family about medication side effects, including frequent skin assessment during phototherapy, is essential for patient health and safety. Skin trauma. It's all ages, increase in elderly, anticoagulated patient, malnutrition, and those with sensory vascular compromise. Traumatic injuries to the skin are the result of external sources and are classified as an acute wounds. There are many types of traumatic skin injuries, including laceration, abrasion, excoriation, friction blisters, skin tears, um, pressure injuries, and burns. And pressure injuries are discussed in more detail later in the chapter, and burns are discussed in the next chapter 51. So it's a very complex section. So I said acute wounds and deep. With clinical manifestation may, depending on the size and depth of the trauma, swell injury to underlying structure, including blood vessel, muscles, and bones. Wound healing is important in the re-establishing skin integrity and has four phases. Hemostasis, inflammatory, proliferative, and maturation. And each phase has specific clinical manifestation and reflect whatever the healing is processing normally. We have by primary, secondary, and tertiary. They are a picture. Also, we went over in previous chapter. Dressing, maintain moist environment. These are the foams, hydrocolloids, alginates, and films. Pain control, infection, prophylaxis when indicated, precise documentation. To evaluate care outcome, acute traumatic wounds usually heal without consequence. Educating the patient and family about the clinical manifestation of the infection is very important in managing wounds. Because aging skin is a even greater risk for trauma, awareness of potential environmental hazards can minimize traumatic injuries. Ensuring that wheelchairs are in good repair, floors are clean from clutter, beds kept very nice in their lowest positions, and patients are positioning with the head of bed at least at less than 30 degrees when possible, and are ways to minimize environmental risk. Lastly, evaluating and maximizing nutrition for patients with an open wound supports healing. Overview of pressure injuries. So careful assessment of risk factor, skin, wound, and nutrition guide the clinical decision making process. Uncomplicated wound healing and prevention of further tissue damage are the ultimate goals in treating pressure injuries. We have common in immobile, malnourished, incontinent, and critical ill, device-related injuries increasing, The pathophysiology and clinical manifestation, we have the pressure, so it's capillary closing pressure, and staging 1 to 4, and then unstageable deep tissue pressure injury. Patients in many healthcare settings are at high risk for damage to skin-related pressure, but also nowadays at home, patients refuse to go in hospital, and they, by being immobile, they develop these pressure injuries, and because of malnutrition and sedentary life, and because of the complexity and cost in treatment of complicated pressure injuries. And surveillance and prevention are primary nursing consideration. Pressure injuries, before we knew that it's called pressure ulcers, now it's pressure injuries because it's an injury, are a common health problem among individuals, those limited to bedridden, or include the localized injury to the skin. Complications of pressure injuries include infection, both local and systemic. The nurse's goal is to limit pressure and shearing to prevent pressure injury development. Treatment includes different approaches. The burden scale on admission and every time. Documentation is a key about the wound. You need to turn and reposition at least every 2 hours. Make sure that the heels and every, like elbows, ankles, knees, and heels are very, and shoulders. They and also the back of the head, or when they stay on the side, on the ear. So the treatment is like cleanse with normal saline. This is always we clean with normal saline. Topical antimicrobials, and also some oral for infected wounds. Manage pain. So it's before making the wound care, it's, or repositioning, administer as needed pain medication, and make sure that the patient tolerates well. Always provide the assessment with vital signs, because it reflects systemic status related to infection and hydration status. An elevated temperature, like fever, may be indicative for infection, with sepsis, tachycardia, and hypotension might be also developed. Pain, always make sure is no pain. So pain, pressure injuries may cause pain because of edema and pressure in the area, as well as the exposure of nerve ending and large wounds. Functional assessment, it's that provides data of the patient mobility status, how many hours per day the patient sits or laying down, and typical activities of daily living, we call it ADLs, including the type of work. It's also important to ask what kind of bed and or wheelchair surface the patient uses. When you assess the skin, admission, the skin and risk assessments identify patients at risk of developing pressure injuries and those who already have existing signs of pressure. Pressure-prone areas, depending on positioning, different areas are at increased risk for pressure and decreased perfusion. Patients who are supine are at increased risk. Supine means on the back, laying on the back, increased risk of pressure to the occiput, like in the back of the head, scapulae, sacrum, ischium, and heels, because they are very bony and there you don't have much muscle, and then little ulcer will lead to a long time to heal. Risk assessment, Barden scale. Admission assessments identify which patients are refusing treatment and provide the basis of their refusal. Help define initial care approaches and provide documentation which must occur every 48 hours in acute care, weekly, long-term care, and on every home care visit. We have the wounds assessment. Should include location, injury stage, wound measurements, length, width, depth, tissue type, the presence of infection, escodate, and description of peri-wound skin. You need to check and assess nutritional status, screening on patient admission during the admission process, with referral to nutritionist if found to be at risk for malnutrition. Think about the diabetics. They need the dietitian and registered dietitian in diabetics for the diet. Wound healing requires increased protein, nutrients, and hydration. Make sure what type of diet they have. Some patients, they have lifelong vegetarians or vegans, so make sure on that. Collaborate with dietitian here. Past medical history, you need to make sure the history of previous pressure injuries increases the risk of new injuries, as well as potentially resulting in delayed wound healing. The lab serum, albumin, and pre-albumin, this is the nutritional status, is important to skin integrity and wound healing. Decreased serum albumin and pre-albumin may indicate nutrition deficits. Think about the blood values of the C as a cat, C-reactive proteins. Those values are elevated in infection and inflammation and are good indexes for monitor resolution. Now the nursing action, positioning to decrease pressure on bony prominences. Skin breakdown starts to occur within 2 to 6 hours of the onset of the pressure. Repositioning is very essential, and the immobile patient to reduce pressure or bony prominences and pressure injury risk. Reassessment of pressure prone areas during repositioning helps to guide repositioning treatment plans. Keep the head of bed elevated at 30 degrees. Keeping the head at 30 degrees affects the shearing forces by minimizing the patient sliding down in the bed. You need to use draw sheets to reposition the patient. Those draw sheets decrease the effect of friction by not allowing the patient's skin to be dragged along the surface of the bed. Also, you need to control moisture and cleanse the patient immediately after incontinence. Urine and feces irritate the epidermis, increasing susceptibility to skin breakdown. Apply moisture barrier ointment to skin subject to incontinence. Increased moisture on the skin causes maceration, increasing to skin breakdown. You need to obtain appropriate bed surfaces. Can be selected according to the patient clinical presentation and redistribute pressure. Wound care. We need to clean, dressing. So the wound should be done according to the wound dressing recommendation and clinical evaluation. And wound dressing should be chosen according to the needs of the wound. Documentation of the wound progression with each dressing change, or at least weekly. Wound documentation provides the status of the effectiveness of therapies and can guide further treatment decision. Nutritionist referral will develop a diet plan specific to meet the patient's needs of a specific open pressure injuries. You should administer antibiotics as prescribed for infection. Infection inhibits wound healing. Physical therapy, occupational therapy referral, rehabilitation therapies maximize a patient functional status to apply the patient to be an active participant in their own care. Provide emotional support to the patient and refer to social work if needed. Patient with a chronic wound can experience a decreased quality of life as a result in depression. Provide emotional support to caregivers and refer to social work if needed. Caregiver can experience role strain when caring for a person with chronic illness. Nursing teaching, importance of turning and repositioning, patient and family compliance increase with teaching about the relationship between the lack of movement and pressure injury development. Nutritional requirements, adequate wound healing requires adequate nutrition. The patient needs to consume an adequate intake of proteins and carbohydrates. Importance of adequate fluid intake. It's associated with normal skin turgor, and dry, scaly skin increased the risk for loss of skin integrity. Clinical manifestation of infection. We know that by recognizing of infection is important to minimize the risk of systemic involvement. It's very complex section of the book. Please look over in the chapter for more in depth. And now we go to the next section of the chapter. Skin cancer. We have skin cancer is the most prevalent type of cancer, and exposure to the sun is one of the primary risk factors. Ultraviolet damage the DNA of keratinocytes, increases with extended time in the sun, and is a major contributing factor to the development of skin cancers. Non-melanoma skin cancer includes basal cell and squamous cell carcinomas. The most serious of all skin cancer is the malignant melanoma that originates from melanocytes found in the basement membrane of epidermis. Skin is divided in three sections: epidermis, dermis, and this is on the basement because epidermis has also 5 layers. Even if it's so thin, this epidermis also has 5 sections. Treatment of skin cancer, can be very complex, including surgical excision, chirotherapy, radiotherapy, topical chemotherapy, photodynamic therapy. So this is another skin disorder. Patient with skin cancer might have to deal with body image and disturbances. And as we know, the non-melanoma skin cancer include basal and squamous cell carcinoma. I haven't talked about the actinic keratosis, are atypical keratinocytes found in the epidermis and present in the most common form of precancerous lesion. And just this ultraviolet light, too much exposure from the sun, damage the DNA of the keratinocytes, which increases with extended time in the sun, and it's a major contributing factor. The average age of diagnosis is around 65. Before age 50, more in women are diagnosed with melanoma than men. Both basal cell and squamous cell carcinomas have a higher incidence among the solid organ transplant population, most likely because of immunosuppression therapy. And interpersonal management, we have the diagnostics and skin exam, the treatment. Here at the nursing, we have a lot of sun safety education. The nursing action is to provide pain medication as prescribed, especially for post-procedural pain, post-procedural pain. Some treatments of skin cancer involve surgical like a excision or topical therapies that can disrupt the skin, causing pain. So provide pain medication. Provide emotional support. A diagnostic of skin cancer can evoke fear and concern over alteration in body image, prognosis, and finances. Refer to social work or psychologist. It's because the skin cancer can provoke fear related to the diagnosis and prognosis, and referral for counseling, it's very indicated. Now you need a nurse keep in mind teaching limit to the sun exposure, because the sun is directly related to the development of skin cancer. There are specific actions that can minimize exposure, including the application of sunscreen and wearing hats and long sleeve, as well as limiting exposure during the time when the sun is at the brightest. Here with long sleeve, when I go to walk my dog, I have long sleeve, ultraviolet that keeps the UV light, and actually it's a swim. It's a swim long sleeves, but I use it. Sunscreen use, so usually it's recommended 30, but be careful that fully exposed to harmful UV rays, it's for 1 minute of every 30 minutes in the sun. So sunscreen should be applied thick and reapply at least every 2 hours or more frequently if swimming or exercising. Even if it is waterproof, gonna go away. So umbrella if you stay outside or shadow somewhere. Skin self examination. Skin cell should be performed monthly, looking at both anterior and posterior surfaces as well as the top of the head, soles or the feet and palms of the hands. Of course, palms, it's on the hand. Wound care for post-operative, like after the operation, post-operative incisions or effects to other skin cancer treatment. Sometimes they do the biopsy and they cut a little bit of piece of skin, so might be sometimes you need to do wound care for this. Education about proper wound care decreases the risk of infection and promotes healing. Information about the different types of skin cancer, because not all skin cancer have the same prognosis. Education about the specific types of skin cancer may alleviate the concern. Providing patients and family with contact information for local chapters of the American Cancer Society support groups can help patients to get help to cope with a new diagnosis of skin cancer. We need to evaluate the treatment for the skin cancer. Begins with teaching about the risk and ways to prevent the development of skin cancer. The prognosis of actinic keratosis, basal cell carcinomas, and most squamous cell carcinoma are much better than those for patients with malignant melanoma. Education for patients treated for actinic keratosis and basal carcinomas include an explanation of prognosis as well as ways to decrease risk factor. emotional support and connecting the patient and their family with appropriate community significantly helps the patient and with a new diagnosis of melanoma. More it's on the cancer chapter. There is a very more detailed there. For reconstructive surgery is performed by a plastic or reconstructive surgeon following trauma surgical debridement of a wound, excision of cancerous lesion, or repair of congenital defects such as cleft lip or palate, to refer to improve functional deficits. Epidemiology: more than 52 million reconstructive surgeries are performed each year in the United States. There are two distinct groups of patients who require those reconstructive surgery. Those who need surgery become of congenital defects because of congenital defects, or disfiguring birthmarks, and those who need surgery because of trauma, excisions of tumors, infection, or chronic wounds. The most common reconstructive surgery performed by the plastic surgeons were for cancer reconstruction and wound repair with closure. Tumor removal and repair accounted for approximately 90% of those reconstructive procedures. Those surgeries include like scar revision, laceration repair, dog bite repair, hand surgery, burn care, breast reconstruction, and microsurgery. And pathophysiology: we have the plastic surgeon performs primary closure of the wound with minimal scarring if the edges of the wound are fairly straight. For wider wounds, surgical debridement and healing by secondary or tertiary intention may be required. Healing by tertiary intention includes the use of skin graft, myocutaneous skin, subcutaneous tissue and muscle, the fasciocutaneous skin, subcutaneous tissue and fascia, and free muscle flaps. So we know that those two distinct group of patients who require reconstructive surgery, those who need because of congenital defects or disfiguring birthmarks, and who need surgery because of trauma and infections and chronic wounds. Then we have interprofessional management, the pre-op. Make sure that it's a glycemic control, stop smoking, manage anticoagulants, post-op nursing, frequent checks of flap graft perfusion, color, temperature, capillary refill Doppler, protect from pressure, shear, manage drains, negative pressure devices, maintain normothermia, hydration, pain control, infection. We have complication, hematoma, infection, flap graft failure, and notify surgeon promptly. So nursing care of the patient undergoing reconstructive surgery extend from the preoperative to the post-operative periods. The nurse focused on these diligent assessments of the wound as well of the graft shift, and it's attentive to signs of infection, decreased perfusion, and delayed wound healing. Additionally, elevation in white blood cells count, this is the lab blood, must be reported to the provider because it's infection. Fluid and electrolyte status as well as nutritional intake and are also important parameters to follow in the patient after reconstructive surgery. So this wound care, psychosocial needs, pain management, and astute assessment skills are crucial in managing the reconstructive surgical patient. Position the patient so that they are not laying on the newly reconstructive surgical areas. Positioning the patient appropriately can reduce or eliminate the pressure on the surgical areas, provide emotional support to the family caregivers. Caregivers can experience anxiety and apprehension about their abilities to provide care to the patient. Nursing teaching for everybody, for the family and the patient, importance of following prescribed diet. The hyper-metabolic state of wound healing requires supplementation of protein, energy, carbohydrates, fluid, and vitamins and minerals. Clinical manifestation of infection and decreased tissue perfusion to patient and family. Also teach rapid and early assessment for infection or decreased tissue perfusion of the flap is essential to prevent further injuries, including graft failure. Teach about the expected prognosis of healing. Anxiety can be diminished if the patient and family or caregivers understand what to expect. Wound care, so teach about wound care. Patient with wound healing by secondary intention require wound care throughout the wound healing process. Appropriate methods of offloading, such as push up while sitting, if in the wheelchair, and repositioning while laying down. Wheelchair push-ups, patient lifting body weight up of wheelchair surface every 50 minutes, and the repositioning while laying down every 2 hours diminish the effect of pressure. We know that we need to look forward for evaluating care outcome. For this, we need the patient undergoing reconstructive surgery has many needs during the perioperative period. Perio means before. Success rates of skin graft, muscle flaps, and free tissue transfer flaps can be tenuous and vary by the location of the flap. Health status of the patient, presents of preoperative, pre means before. Infections such as osteomyelitis and post-operative care. Post it's after. Patients undergoing debridement with closure by secondary intention need dressing changes throughout the healing phase and will likely go home with an open wound. The patient and family or caregiver require support to help them meet the physical and psychosocial demands of wound healing and the prescribed course of treatment. The goal of treatment is a well-healed wound and improve functional status of the patient. So the skin and its structure serve as a protective barrier against microbial invasion and environmental exposure, and skin disorder cause a compromise in the skin integrity, thereby facilitating the risk of infection and injury to the patient. Nursing intervention can provide fortification of the medical barrier of the skin through education, support, and proactive recommendation. Once skin breakdown occurs, however, nurses must be able to assess, implement, and evaluate the patient before, during, and after treatment. This requires knowledge of skin infections, wound healing, and therapies used in treating patients with skin and soft tissue disorders. And that's it for this chapter. It's being a long chapter, very complex. I hope make it simple for you to understand, and I'll see you in the next one. Thank you.
We finally made it!
Thank you again for your time and trust. I'm Mia, and from my heart to yours. Until next time, stay zen, stay grounded. Namaste. Bye for now.